Today, the topic for today is when normal TSH isn't normal. So today I want to address what to do with a patient, or if you are a patient whose chief complaint is fatigue, and you're really convinced that they have hypothyroidism, but their TSH is normal. So what do you do next? So, of course, first, if you're listening to this and you're not a physician, please keep in mind scientific proof is not nearly as black and white as people think. And in order to make treatment decisions for individual people, sometimes we have to consider evidence that's not nearly as absolute as we'd like. So this today is not meant to be medical advice, and you should consult your own physician for any medical issues or diagnosis that you may have. All right, let's get into it. What do you do if your TSH is normal, but you're not normal? Let's face it, there's a lot of reasons to be tired. And it's likely that any given patient has more than one of those at a time. Sleep apnea, anemia, depression, diabetes, those are just a couple. And when you look at thyroid symptoms, taking each one alone, almost all the symptoms of low thyroid could all be caused by something else, any number of things. But there are some people who just fit the pattern because they're not only tired, but their hair is thin here on top. Their complexion is puffy, pale. They have weight problems. They're fatigued. They're sleepy, but they sweat at night, puffy ankles, way more. I've covered that subject in a lot of detail in some earlier live sessions. And so we doctors were taught, check the TSH. Okay, there's even a test called reflex to T4 so that we can check that one, and it gives us the TSH. And if it isn't normal, it doesn't even check the T4. So we don't look any further if TSH is in the referent range. Even a complete thyroid panel has outdated tests that don't actually check the free hormone levels, which are what actually act in your body. But I want to offer you that there's an additional test that needs to perform, and a better way to test, and a better reason to look deeper, because some of the problems of thyroid metabolism are not with the gland itself, but what happens to the hormone after it heads out into the bloodstream to do its job. So T3, which is the active form of the hormone, and T4, which is the storage form of the hormone, while they're in the thyroid gland and out in the bloodstream, are mostly bound by protein, which helps it be water soluble so that it can go into the blood, which is aqueous, and get to all the target cells of your body to do what it does for your metabolism. So T3 is the activated form, and it is converted from T4 either inside the thyroid gland to T3, or in the cell itself, in the target cell. In the thyroid gland, it's maybe in about a 10-to-1 ratio where it's released into the bloodstream, and then converted in those target cells by after it is released from the protein and transported into the cell. It is transformed into the active T3 by something called 5'-deiodinase enzyme. And about 80% of the T3 that works on your body cells comes from conversion at that cellular level. And there are a lot of places where your body can regulate or modulate this process. So one way is that there are 3 different kinds of deiodinase enzyme. So type 1, 5'-deiodinase type 1, makes a different version of T3, 5'-deiodinase type 2, 5'-deiodinase type 3. I'm having confusion in my brain right this second on which one is which. I think type 2 is the one that makes the active form of T3. Whereas if a different deiodinase is acting on the T4, it gets made into a slightly different formulation. It still has the same number of iodine molecules, but the iodine comes off of the wrong spot. So it's like a key that'll fit into the lock. And if T3 is this one, then there's another one called reverse T3, which is this one. And it will not turn the lock, so to speak. So reverse T3 made by 5-deiodinase type 3 will bind to the T3 receptor in the nucleus, but it won't activate it. So it sits there and basically blocks. And neither T3 nor reverse T3 can displace one another. So whichever one got there first is going to be the one that acts. And if reverse T3 is sitting on the receptors, then basically nothing happens in the DNA. The cell is not activated. The metabolism is not stimulated. Now, there's a bunch of other stuff that can happen to T4 once it gets into the cell. It can be decarboxylated, deaminated, conjugated, ester-linked, cleaved. So there's a lot of reasons why T4, just because T4 is in your bloodstream, doesn't mean that the active byproduct of T4 is getting to the cells. So now, well, okay, so why do we have reverse T3? Well, it does have useful functions. It is very good in embryology, where you have rapidly growing cell types, and it blocks unblocks, mitogenesis and promotes rapid cell growth. And wound healing, you can see that rapid cell growth is also a useful thing. And so it's nice to have high levels of reverse T3. Interestingly, where you see really high levels of reverse T3 in patients on a routine basis is in the ICU, when people are seriously, severely ill. So they will get very high levels of reverse T3, sometime to the point of what we call sick euthyroid syndrome, where they're acting like they have no thyroid hormone at all. Their metabolism just shuts down. And if you give them T4, it doesn't help them. But if you give them T3, it actually does help them. So T3, there's a lot of reasons why people will have elevated reverse T3, even if their TSH is normal, even if their T3 is in the normal range. And it's not rare. This is not a rare problem. The causes are stress and elevated cortisol. And we Americans, we are stressed, sometimes even from childhood, actually very frequently from childhood. So think about the new research that's coming out about ACEs, which are childhood traumas like divorce or death of a parent. And then 15 to 20% of the US has Hashimoto's antibodies, up to even 24% of some subclasses like allergic women, or 20% of patients with celiac. Another thing that will cause very high elevated reverse T3 is our diet culture. So a calorie restricted weight loss program, your body interprets that and reacts to that just as if you were starving. And one of the things that happens in starvation is very, very high reverse T3 to basically shut you down so you don't burn up all your muscles. And then there are a lot of iatrogenic reasons why people will end up having reverse T3. For example, very high iodine intake will trigger basically a shutdown of thyroid function by elevated reverse T3. A selenium deficiency, selenium is required for these deiodinase enzymes. And so a lot of times a selenium deficiency will do it. And then there are supplements that actually contain sometimes reverse T3, sometimes T3, and it is not tightly regulated by the FDA. So these supplements can contain levels of T3 that are far beyond anything that they ought to contain, because T3 is a hormone. It's a drug. You shouldn't be taking it in a supplement. And then there are people who take thyroid in a factitious way for what they think it's going to help them with weight loss. And then Graves' disease. Graves' disease is antibodies that stimulate your thyroid gland to just produce more. This is a defense mechanism to stop your body from just burning up from the Graves' disease. It helps block those T3 receptors so they don't cause as much damage. And then there are some drugs that will cause this. Amiodarone is a big culprit, and then beta blockers. And then the final one is loss of sleep. And truthfully, it is very simple to figure out whether somebody has too much reverse T3 or not. And because reverse T3 is present in your body in such small amounts, there is no test. It would be below the lower limit of detection. There is no test for free reverse T3. So when you test reverse T3, when you test reverse T3, it is important to compare it to total T3, which is the protein bound plus the free. Because there is no free reverse T3. So when you get those two tests, total T3 and reverse T3, then you compare them and you say, I'm going to make a ratio of total T3 divided by my reverse T3. And it's very simple. If it's above 10, it's good. If it's above about 17 or 18, it gets not so good. You need a little bit of reverse T3 in your body. But anything below about 10, your patient is likely not having ideal thyroid function, and they're not going to feel that well. I do also recommend checking TSH, free T3, and free T4. So those 5 tests are what I routinely test on anybody that I suspect with thyroid issues. And there are so many more details about this. And I will tell you that the clinician's course that I am proctoring is now addressing exactly how to do this. And we're going to do that this coming Sunday. And in the next few lectures, we're going to hear really the latest insights into thyroid physiology, including how to use some select supplements and FDA-approved preparations to balance and optimize not just thyroid, but all the different hormone systems for men and for women. And we're going to continue this course each Sunday, almost up to Christmas holidays. If you want to join us, the live sessions are free. And then the replays and the slides and other supporting documents are available for an administrative fee. And you can have that at my sister website, and it's on the banner down below, www.allergyaccessmd.com/endo-opt-in is where you can find that course. So that's it for now. I'm Dana Gibbs, MD. I'm an integrative physician in North Texas. I help people address thyroid and other hormone imbalances. And if you're a thyroid or chronic fatigue sufferer in North Texas and you want a caring doctor to help you resolve your exhaustion, joint and muscle aches, poor sleep issues, and weight gain, come sign up for a new patient evaluation with me now at www.danagibbsmd.com, or you can send me an email, drgibbs, Dr. Gibbs, at danagibbsmd.com to ask me questions, and I'll answer them in the next Tuesday Live. All right, guys, thank you. That's it for the day. I'll talk to you again next week. Bye-bye.